At this time, I'm pleased to introduce our first speaker, Christopher Carroll, who is Director of Healthcare Financing and Systems Integration for the Substance Abuse and Mental Health Services Administration. We're so honored he's with us today to provide an overview of the many federal initiatives to increase access to behavioral health services and ensure these services are integrated and coordinated with physical health services. Chris?
Thank you, Catherine. On behalf of the Substance Abuse and Mental Health Services Administration and its leadership, I'd like to express my gratitude to the National Institute for Healthcare Management Foundation for the opportunity to present today. It's a great opportunity for us. And to thank those that are in attendance. I'd also like to thank you, Catherine, for the invitation and for arranging this, as well as my longtime colleague, Sarah Wattenberg from ONDCP, for sharing this time with me. I hope you find what we present today both interesting and actionable. And with that, we'll go on to what we're going to cover. So this is the agenda. We don't have a whole lot of time, so we'll be as quick as possible here, but I'd like to give you a brief overview of SAMHSA, some of the real costs and consequences of our healthcare system, some of the federal efforts around system services and payments, and then to end with kind of what to watch out for, what you all should be looking for. So this is the SAMHSA budget overview. SAMHSA's 2016 budget is about $3.7 billion, which is about a $45 million increase from the fiscal year FY15 budget. Our priorities, I think, are in specific areas: strengthening crisis system, addressing prescription drug and opioid abuse, expanding the behavioral health workforce, and the President's Now is the Time plan. Now, the President Barack Obama released Now is the Time as a plan to increase access to mental health services. SAMHSA played a key role in supporting a number of activities outlined in the plan that's available on the web. It does include development and funding of new grant programs, collaboration across HHS and with other federal agencies. It's very important for us to support Now's the Time, and we do feel that our budget supports the President's commitment to investment in the nation's health through key behavioral health priorities. So, system cost. I think everybody has seen this. We have known this for a long time, that mental health conditions were extremely costly. I don't think the data was exactly lined up right for a long time, but in Health Affairs, in the recent release of Health Affairs, the data was paired in a way that starts to express the magnitude of system costs in delivering behavioral health. And this is kind of the way that it was paired up. So you can see civilian, non-institutionalized, and institutionalized and active duty military. When you combine those two major sources of services, you get significant system costs, more than heart conditions, more than trauma, more than cancer, more than heart disease. It's a significant issue for our healthcare system moving forward. Like I was saying, I think we have known this intuitively for a long time, but this data is especially helpful in us relating that case. So if we are to drill down just a little bit from system costs, we can see the costs of mental and physical health comorbidities. On the left-hand side of the screen, you see some Medicaid numbers. On the right-hand side, you see Medicare. Now, these charts say essentially the same thing, that treatment of specific conditions and chronic diseases become exponentially more costly as behavioral health conditions co-occur. You can see from the left on each of the slides, there's no mental illness or substance abuse, and the cost associated with that. You start to layer on mental illness and no drugs and no mental illness, and on the far right-hand side of the Medicaid data, you see mental illness and drug and alcohol cost, how much that raises the cost of care. Same is true on Medicare. This is with chronic conditions and severe mental illness. So impacts on physical health. Mental health problems increase the risk for physical health problems and substance use, increase the risk for chronic disease, sexually transmitted disease, HIV, AIDS, and mental illness. The cost of treating common diseases is higher when a patient has untreated behavioral health problems, mostly preventable or treatable. In the box to the right, you can see diabetes treatment, patients per year. With diabetes alone, it's about $50 million. With a behavioral health condition, about $250 million. So significant impacts on cost related to co-occurrence of disease. So these are some of the cascading consequences. And we know that behavioral health conditions are really just a huge public health issue. We know that there are many things as it relates to behavioral health that start to have significant impacts on people. So in 2014, nearly 1 in 5, or roughly 43 million adults, had a diagnosable mental health disorder, yet only about 55% did not receive mental health services in the past year. There were 41,149 suicides in 2013. At the rate of 12.6 for 2000 equals about 113 suicides each day, or 1 every 13 minutes. We know opioid misuse is a growing public health problem. Estimates show a 150% increase in opioid-related hospital stays over the last 2 decades, yet only 17% of patients engaged in treatment within 30 days of discharge. Drug overdose is the leading cause of accidental death in the U.S., with 47,055 lethal drug overdoses. It's about 129 opioid deaths per day in the United States. And what all this really means is about 80% of those people that are experiencing behavioral health conditions present only or primarily only in specialty medical or surgical settings. So all of these things up here around suicide and opioid misuse and mental health conditions may seem to be specialty behavioral health treatment issues. Practically, they're being seen in primary care and general medical settings. So just from the 30,000-foot view, there's a number of things that SAMHSA and its federal partners have been engaged in. Our relationship with CMS is very important to us. As the largest payer of behavioral health services in the United States, that's important that our wonderful partners at CMS help us, and we help them to identify issues that are important within behavioral health systems. We do this through delivering informational bulletins. We've done informational bulletins on medication-assisted treatment, coverage service assigned of behavioral health services for youth. We have ongoing interactions with them around payment rules, waiver consultation, state plan amendments, regulation review, quality measures, same-day billing guidance, and parity. Of particular importance is a new grant program, a demonstration grant program that SAMHSA is putting on, which is called Section 223 of the Protecting Access to Medicare Act of 2014, which starts to certify community mental health centers as certified community behavioral health clinics. SAMHSA has managed the criteria development there. CMS has developed the prospective payment system, and our friends at ASPE, Assistant Secretary for Planning and Evaluation, will evaluate the programs and its outcomes. Another large effort that we have been working together with our partners at HRSA is the SAMHSA Center for Integrated Health Solutions, which starts to move different practices and policies around integration into practice in communities. This starts to show itself through a number of different federal initiatives and efforts to support integration. And when SAMHSA talks about integration, that's, I think, more specific to our grant programs that we run and the types of individuals that we serve, which are individuals with serious mental illnesses. So as we think about that, the Office of the Assistant Secretary for Health, a few years ago, maybe 5-7 years ago, we started seeing the data on the importance of addressing comorbid conditions in individuals, especially those with serious mental illnesses who have life expectancies significantly shorter than the general population. This translates into SAMHSA's PBHCI program, which is primary behavioral health care integration grants, of which is about $100 million in grants with 100+ sites. We're also very interested in primary care and addiction services. We've not gotten a tremendous amount of support, congressional support or other support on that, although we're seeing the comorbidities around substance use and substance use conditions are as, if not more significant than those with serious mental illnesses. There's other things across the CDC, such as Million Hearts and AHRQ. CMMI is the Center for Medicare and Medicaid Innovation, is doing a lot of tremendous things to test grant models using SAMHSA and AHRQ indicators. Medicare Accountable Care Organizations, the Next Gen Accountable Care Organizations show promise as well. Wrapping up here, service models, payment structures, and demos to achieve better care and value. State innovation models, I think, are really, really interesting and show promise. Health homes, our partnership with CMS has been particularly helpful there. We've done 50 consultations with 25 states. The duals demo, I think, shows promise. Transforming Clinical Practice Initiative, which is a large technical assistance and training effort out of CMS, which is designed to help clinicians achieve large-scale health transformation. The Medicaid Innovation Accelerator Program, focusing on 3 areas. One, most importantly, is substance use disorders. And this one is particularly important, I think, as CMS changes to the physician fee schedule, the collaborative care model in primary care. That we are encouraged to, that CMS is taking that, is using that payment lever to affect change. That's broader than integration, I think. It's not SMI focused, but it still holds promise as we look at those co-occurring disorders. So I would encourage you really to take a look at that, which will be effective, I believe, January 1, and we may hear a little bit more about that in just a little bit. And here are the New Horizon issues that I wanted to just make sure that you all pay attention to. There are even more new payment and service models and grant programs coming out of CMMI, with particular focus on population health. The President has just this year established a task force on mental health parity in the Addiction Equity Act. That task force is holding meetings with different constituents. It will produce a report by October 31st to the President. I think that there will be actionable, concrete steps that are defined for what the government should take action on, and I think it would be telling as well for you all to see what's going on. Value-based purchasing and pharmaceuticals, this is very interesting as well. Expansion of opioid treatment. SAMHSA is doing a lot. You may have seen that we have expanded the limit of the number of doctors that can prescribe buprenorphine from 100 to 275. And an issue that's particularly promising to us is the further development of behavioral health quality measures. We really need to, with the importance of behavioral health, we really need to be able to turn to the quality measures and say, do the services that we provide work, and are people getting better? So with that, I will leave it there, and I guess turn it back to Catherine.